Hi, I have case C, and the differential diagnosis I came up with are vestibular migraine, BPPV, and chronic vestibular hypofunction. All three of those have spinning vertigo, which is a complaint she has. Vestibular migraine, she has a past medical history of migraines, sensitivity to light and sound, and she's also having episodes of symptoms. With BPPV, BPV also has just like episodes of symptoms, and she complains of like positional changes being like a trigger of her symptoms. And for chronic vestibular hypofunction, she complains of like being in busy places causing her symptoms to come on, so that can happen with vestibular hypofunction. The main diagnosis that I believe that she has is the vestibular migraine. I was able to rule out a few of the other diseases because she has spinning vertigo. I know she doesn't have mal de débarquement or 3PD. The episodes last 2 hours, so she's not having constant symptoms, which would make me believe that she would have vestibular neuritis, so we could rule that out. She can decrease her symptoms by being in a quite dark room. So that kind of makes me believe that it's not BPPV, although maybe she has BPPV with the vestibular migraines, but we'd have to rule that out with special tests. And for chronic vestibular hypofunction, she doesn't have a history of a viral infection or GI infection, so we can kind of rule that out, as well as long COVID. She doesn't complain about having anything like that. She has vertigo symptoms that doesn't occur with her headache, so that kind of goes with vestibular migraine as well. Typically, the signs and symptoms happen after a headache. So I believe that she has the vestibular migraine. I also want to add that for vestibular migraine, you have to have more than 5 episodes, and those episodes should be within 5 to 72 hours. And since it's a 2-hour time that she's having the episode, that also helps us choose that it's the vestibular migraine as a pathology. So going through the tests and measures, spontaneous nystagmus and gaze evoked nystagmus are both absent. So that tells me that the etiology is probably not peripheral or central, meaning the spinal cord and brain probably doesn't have like a lesion, as well as the peripheral vestibular nerves are probably intact and are okay. The VOR and the dynamic visual acuity kind of go together. So she's not having any like saccadic movements, but she feels dizzy, which makes sense if she's trying to avoid certain movements. This might be like a symptom that can lead to like the vestibular migraines. For smooth pursuit, smooth pursuit and saccades are both normal, so that means that she's still not central. High impulse test are both normal, which kind of leads more to not having the peripheral involvement, so that kind of rules out the vestibular hypofunction even more. Dix, Hall, Pike, and Roll tests are all negative, which means it's not BPPV. For the modified CAT-SIB, condition 4 is positive, so her vision's occluded and her proprioceptive ability is occluded, so she's having to use her vestibular system more, which kind of goes with her symptoms. For the sharpened Romberg, having her eyes closed and having excessive sway with like her in tandem stance means that she probably has more of like a visual dependence. And for outcome measures, the FGA, all of the outcome measures are kind of leading to that she's a fall risk. FGA being 22, for the elderly, just having like 22 or lower is a fall risk. The DHI is just saying that like her dizziness is affecting her life, especially since she's complaining about work, not being able to work, and that she's having anxiety over her dizziness. The ABC, anything less than 67 is usually a fall risk. 80 is actually pretty like okay, but it's still like she's not confident with her balance. So and she complains of having balance difficulties, so we need to address that. And for the tug, 15 seconds is a fall risk. It should be less than like 11 for vestibular etiologies. And for the 10-minute walk test, she's a community ambulator. She's between the 0.8 and 1.2. Since she's like in her 30s, we'd expect her to, especially young 30s, we'd expect her to be at that higher level above 1.2. So we'd want to address that. For the treatment of vestibular migraines, we'd want to address and control the migraines themselves. So we'd want to educate about diet, sleep, and stress, and maybe refer her to a dietitian or a psychiatric doctor to help with those components. For her symptoms, we'd also want to do vestibular rehab, so gaze stabilization to really address her positive VOR, the habituation exercises since she's having symptoms when she changes position, and balance because she complains of being off balance. A gaze stabilization exercise we can do is ×1. And so the patient would begin in seated and have a piece of paper with a mark on it. So we just have an X here and begin with just having arms length away of holding the paper and looking at the X, and then just moving their head to where they can see the X clearly, maybe just like slightly fuzzy, but moving at a speed where they can see the X well. We want to get to where they're moving their head faster in a standing position. And then she would probably perform this for like 10 seconds, 3 to 5 times a day. And then we'd be progressing to her performing that for 2 minutes straight, 3 to 5 times a day. For the habituation exercises, we would want to perform the MSQ to see which positions are aggravating, but not too aggravating, so that she can perform them. If she was scoring a 2 to 3 out of 5, we would choose that exercise, and we'd have her perform it. So if her lying down is aggravating, we'd have her in the seated position, have her lay down at a speed to where her symptoms come on, but aren't too overwhelming. Have her relax there until her symptoms go away, wait 30 more seconds, have her come up out of that position, have her wait till the symptoms go away again, wait another 30 seconds, and then take a rest and have her perform that movement 3 times. We'd want her to do that with like 3 other positionings to be able to get her habituated to the movement where it's not aggravating her symptoms as much. Her brain's getting used to those movements.